Dear friend, dear colleagues, it's my pleasure today, again at the UROONCO TV platform, to welcome Professor Gontero. Professor Gontero, good morning, bonjour.
Bonjour.
It's my pleasure to have you with us today. You are the chairman of the non-muscle invasive bladder cancer guidelines. And we have you today because the new EAU guidelines have just been released. And I would like to just discuss with you what is new and what's coming for the next years. So first of all, Paolo, in your opinion, what do we have changed in non-muscle invasive bladder cancer? What is new?
Thank you very much, Benjamin, for your question. Well, I think that, first of all, we have made a recommendation based on the WHO 2022 that the pathologist should give the substaging, because we have been talking about that for a long time. I know there is no agreement, there are different systems to classify this, but the time is right that we start to consider this important risk factor in T1 disease.
And we don't call them variants anymore, but subtypes, which is important.
That's the substaging.
And substaging in T1 and the variants in subtypes. Sorry, yeah, true.
And what is important to realize is that more and more probably we'll be able to give the pathology with a good sample just because of the expansion of the M-block technique of TURBT, which I think is picking up. I think it was probably no more than 10-15% of the TURBT, but I'm sure that in the near future this rate will increase. You know, the guidelines don't take a position between piecemeal TURBT and M-block by saying that one is better than the other one, but certainly one of the advantages that has been shown in M-block resection is that the base of implant is better preserved, and for the pathologist is much easier to analyze the submucosa and the muscle layer.
Yeah, I agree. And in terms of management, treatment management of the different risk classification of non-muscle invasive bladder cancer, have you made some changes from low risk or very high risk, intermediate risk?
Let's say that we have softened the treatment option for very high-risk disease in terms of being more open towards the possibility in very selected cases to do a conservative treatment with BCG with the maintenance of 3 years. Radical cystectomy remains the best option that we have always to take into consideration, but we cannot really bind the patient with surgery, radical surgery, as the only unique possibility. So we have to try to make exception when it's possible, when we have favorable prognostic factors like unifocal disease, and even in cases of histological subtypes. There are situations, for instance, low percentage of the subtype where we can consider the possibility of a conservative treatment.
Okay, and after the treatment there is a follow-up. Have you made any changes? Do we have more information regarding follow-up?
Well, we have been discussing about intermediate risk, and the fact that the follow-up was considered something in between the low intensity of the low risk category and the high intensity follow-up with many cystoscopies every 3 months of the high risk disease. And you know, it was left too much to the discretion of the clinician. So we decided to give some rules. So in intermediate risk disease, which is, by the way, 50% of the non-muscle invasive bladder cancer, first cystoscopy is always at 3 months because it is an important risk factor. Then you can do a cystoscopy every 6 months for 2 years, and then yearly up to 10 years.
Okay.
And then you can stop the cystoscopic follow-up.
Yeah, I think it's very important, and it's very useful for our colleagues that we have now like a kind of great frame on how to follow these patients, because it was usually very heterogeneous how they were managed and followed. And we know that recurrences also occurs at a long time after the surgery, after the treatment. So I think that this new update regarding the follow-up is something that hopefully will impact also the oncological outcomes of our patients if we are able to fit and fix to this template.
Yes, of course, the follow-up has to be adapted according to the risk of progression that we know that for low intermediate risk is relatively low. We also know that maybe in real life doing too many cystoscopy could increase the burden for our health system. We are looking forward to having urinary markers that can replace the low sensitivity of urine cytology, but unfortunately at the moment we were not able to recommend for clinical practice any of the commercially available urinary markers. We say that they are promising, they have a very high sensitivity, particularly for high-grade disease. The negative predictive value is very, very high, but unfortunately we have no evidence, sufficient evidence to recommend this marker as a substitute of cystoscopy. But we know it can be safe when you do it in low intermediate risk patients, particularly for those patients who actually refuse cystoscopy.
But so far we don't have enough information regarding the real clinical impact of the use, and the costs that it has remains questionable at the healthcare insurance
These
policy.
are other issues that also prevent us from, being just very, relaxed to say, okay, you can use the marker, but you use the marker as an adjunct and then you increase the cost, or as a replacement and you need evidence. As a replacement of a formal follow-up.
So we have talked about the follow-up, we have talked about the biomarkers in these years, and I think this is one of, I really like also this chapter in the guidelines regarding low-grade disease and the use of active surveillance. That is a new option, I would say, or strategy in some patients, very selected again, but that's now really in the guidelines as a reasonable options in very selected cases. Right?
Well, we have made a session. We have expanded a little bit the session on active surveillance in spite of no additional evidence. But active surveillance has been around for 20 years because the first publication dates back to 2003. It is safe, oncologically safe, as long as you enroll only patients who are low grade. Of course, you have to be sure that the patient is low grade, so you need a previous pathology, and also you have to look to the tumor and make sure that you are enough correct in defining on visual cystoscopy what is a low grade. But if you look at the available studies, and I must say, it's impressive. We have only a little bit more than 1,000 published patients in 20 years. If you look at the studies, the progression rate is extremely low. And some of these studies also enrolled high-risk disease, which I think it should not be considered for active surveillance. The problem with active surveillance is that the duration is very short. And I think one of the reasons is that the exit criteria are too stringent. When you say that tumor more than 1 centimeter, more than 5 tumors, even if they are low grade, hematuria, but you don't define hematuria. What is hematuria? Then the patient has to exit active surveillance. This probably needs, basically, we need more evidence.
We need more evidence on that.
We need more patients. And probably we need a kind of consensus so that we can identify criteria, because in the end, active surveillance for those multi-recurrent low-grade disease is a good option. Although we are, of course, in the middle of a revolution for treatment, and very soon probably we will have some kind of chemoablative treatment safe that will be probably able to replace active surveillance.
And I would like to finish on another point that is now in the guidelines. As our colleagues may know, we have also patients involved in the EAU guidelines. And thanks to some works, especially for our friend and colleague, Professor Mariappan from Scotland, we have introduced quality indicators, not only for us, but for the patient, in terms of how we can make better in terms of treatment. We have more and more treatment, more complex management, and so on. And so with the team of the EAU guidelines, it has been decided to open with a new chapter on quality indicators. Can you just tell us briefly something about that?
Yes, we introduced this new session. Last year, we introduced the bladder checklist.
Yeah.
And this year, we went beyond this. Because in the end, we are moving towards trying to improve as much as possible the quality of the way that we treat, we diagnose, we treat, and we follow up the patient.
Indeed.
And quality indicators in this respect are a surrogate for good practice. Of course, it's something that we have to work on.
Yeah.
Because Professor Mariappan in Scotland, he managed to actually introduce the quality indicators, and they were able to standardize the treatment and also to make it to see an improvement in the
terms
quality,
of outcomes,
and also in terms of outcomes, in terms of reducing the recurrence rate. In the end, we know that by using the simple bladder checklist, there is an impact, a positive impact on recurrence-free survival. So quality indicators is something that has been placed in the guidelines as, how can I say, as an incentive for our readers in terms of trying to go beyond, to look at the quality of what they do. As an example of quality indicators, reach URBT in patients that needs this procedure. The use of a checklist is a quality indicator. Counseling of the patient to stop smoking. Mm-hmm. Using the risk stratification of the patient is a risk. Discussing high-risk patient in MDT. These are all quality indicators. And now we have a table, so you can look to the quality indicators, but in the near future, we need really studies that we will be able to show how we can really impact on the disease outcome by using these indicators.
Yeah, I fully agree, and I think it's somehow really interesting to have now these quality indicators, because we can evaluate ourselves thanks to these indicators, and also we have a lot of new treatments that are coming, and that might be very expensive, but a very cheap way to improve the management of your patients in non-muscle invasive bladder cancer is, of course, to follow the guidelines, but using quality indicators may help to have a frame of where to go and how to improve it. Professor Gontero, thank you very much.
I fully agree, and I thank you very much for this kind invitation.